Right now, I'd like to introduce Naomi Prendergast, President and CEO of Duval Life and Wellness Community, who is our sponsor for this evening programs. Special thanks for Duval for their generous sponsorship and their program for CMSNE. And she's going to take a couple minutes to tell us about her program at Duval. Go ahead, Naomi.
Great, thanks so much, Karen. And it's really a delight to be able to sponsor this program tonight. Thank you so much, CMSNE, for giving us this opportunity. It will be great to welcome you to our campus as we have several times in the past, but then again, for all of you out there, and I think there are about 55 viewers, it's probably the best commute you've ever had to Lowell. So glad you enjoyed the trip. Just, a few things about Duval, and I know many of you have been here before, but we do have a full continuum of care on our beautiful 75-acre campus in Lowell. We actually have two SNFs, Duval Senior Care and the Duval Center for Advanced Therapy. The latter, Duval Center for Advanced Therapy, does only short stay. The other facility is long-term and short stay, the long-term including 84 special care dementia bed in our special care unit. Between those two, historically, of course, now it's a little bit different in the COVID era, but we know we'll get back to our historical trend of admitting about 100 or a little bit more of short stay patients every single month. We also have on our campus 60 apartments of assisted living called the Saab Residence. That includes 15 memory care assisted living. And what's unique about that building is that about half of the apartments are geared for people of low and moderate income. It's an internal subsidy. There is no, of course, Medicaid funds. It's not GAF related, but we do want to make sure that everything on our campus is for people of all income levels. We also have 63 apartments of HUD 202, which is independent apartments for low-income seniors, which is called Brea Gardens. So between that whole continuum of care, the independent living, the assisted living, and the two SNF buildings, you can tell that we're a very dynamic campus, and a lot is going on. We are accepting admissions currently, and as Mike is going to tell you, we have done a great job in this extremely challenging times. And by the way, our two SNFs are 4- and 5-star facilities, so we have a great track record and an extremely talented team. So now I'd like to introduce our speaker, Mike Ferrick. Mike Ferrick has been at Duval for pushing 4 years at this point. As you can see, he has a great background. He is an RN by background, also a licensed nursing home administrator. And Mike is responsible operationally for the combined 241 beds at our two SNF buildings. As you'll be able to hear, these days, that's quite a challenge, and he does a great job, but is going to share with you a lot of insights of what we have learned since last March. So, pleasure to introduce my colleague, Mike Ferrick.
Okay, so I just got the prompt to get unmuted and start my video, so I'm hoping everybody can hear me. First, thanks so much for the opportunity to present to everybody. We're really happy to be here tonight, and we want to thank you for joining us. And like the title says, we're going to talk about the COVID-19 pandemic and how it's impacted these communal settings for elders, specifically the long-term care industry, short-term rehab, and assisted livings. Me and my wonderful colleagues have some experience with this because we've been very involved operationally, like Naomi said, managing these buildings that have just been very, very hard hit, not only across the state, but nationwide by the COVID-19 pandemic. I think the conversation will mainly focus on that short-term rehab piece and the skilled nursing piece, in the nursing home part, but please feel free to ask questions along the way. We're definitely an open book, and we're happy to talk about anything that you've been thinking about, that you'd like to know about this industry and what it's been like for the last 9 months or so. So the slides are a little delayed. So, okay, let's talk about the spring of 2020. And this was really the first wave of the pandemic. And even we're going to talk a little bit earlier than that, because a lot of this started in February, and I think technically that is before the spring. But this part's really about the preparation leading up to the pandemic. The CDC and the Department of Public Health and our trade organizations like Mass Senior Care really started to encourage us to start having conversations about COVID-19 in middle to late February. And the tone at this point was by no means urgent. In fact, most communications that we got from regulatory bodies and experts had a stamp on the bottom that said, remember, the risk of flu is high right now and the risk of COVID is low at this time. So that there really wasn't an urgent tone at this point. Some things that facilities were instructed to do were to be prepared for a staffing crisis. What would you do if 70% of your staff couldn't come to work? What would your plan be? The outline of that is that you'd make a list of the absolutely necessary services that residents need, like eating, toileting, and medications, and you have to have a plan in place to repurpose your staff to do them. So for example, in a time of staffing crisis, therapy is probably not going to be life or death. So you'd repurpose your therapy staff to maybe do things like provide care to the residents, care that CNAs would normally do. Vacuuming the carpets probably isn't going to be life or death. So you could repurpose your housekeepers to do things like cook food and serve food. But those are the type of things you need to be thinking about if you're going to have a staffing crisis. Also, what's your chain of command going to be? If you have leadership that gets sick or otherwise can't come to work, there has to be a succession plan so people have the authority to make decisions. Often, you start with the CEO, and then you go to the administrator, and then maybe director of nursing. But you want to have a really long succession plan because you just don't know how deep and impacted your staffing is going to be. So you really have to get down to department heads, and how would your director of social work, director of therapy, director of dining, run the building if they had to and they were the person in charge. So you needed to have plans in place if these things came into play. Also, what's your supply chain look like? How will you get water and food? If your vendors are, sick and they're impacted by the pandemic and they don't have staff to drive their trucks and deliver you things, what are their plans to provide you with food and water? And if they can't do it, what's your backup plans? Most facilities keep about 7 days on hand of food and more than water, but you can't go much longer than that without a delivery. So what are you going to do if that happens? Also, start reviewing your infection control practices. Back in the spring, there certainly wasn't anything groundbreaking when it came to infection control to start implementing. It was the things that we've been doing for years to help prevent the spread of infection. Talking about washing your hands. Don't come to work if you're sick. If you interact with somebody that has an infectious disease, talk to the infection preventionist at your organization to see what your instruction should be. Maybe you shouldn't come to work for a certain period of time because you could be sick and spreading an infectious disease without knowing it. Also, review your precaution room policy. If someone has flu symptoms or the flu, and again, this is something we've been doing for years, you're going to put that person in a separate room from other folks, and you're going to have them on special precautions. You're going to have them on droplet precautions. So that means staff would wear PPE, in and out of there, and they wouldn't have a roommate. You're basically going to kind of isolate that person from the rest of the building to decrease the risk of spread and limit the amount of staff members that work with them. The most basic form of infection control, and this kind of relates to what we were just talking about, is separating those who you think are infected or you know are infected from those who you don't think are infected or you know aren't infected. And people figured that out 400 years ago in the 1700s, including, in this area in Boston, when ships would come to port, the ships would have to quarantine for 40 days or so before the shipmates were allowed to come and mingle with the residents of the city. And that was to decrease the risk of spreading, plague or other infectious disease that you didn't want to spread. Even though people didn't know the mechanisms of how infectious disease spread back then, they knew that this quarantine type thing was effective and it worked. And as the presentation goes on a little bit here, we're going to see how quarantine, even though it's the oldest form of infection prevention that we can think of that's been effective, is still one of the most useful tools that we have today, and it's still very much in effect. Sorry, so some of that was covered on that slide there. Down the bottom, I mentioned kind of what I would call a point of confusion, and if maybe even a caveat to the some of the things that we just talked about, and that was on a lot of the guidance that we were getting at this time in the spring about controlling the virus indicated that once you started to find residents or staff to be positive, you need to start assuming that the virus is already spreading in your building, which is totally sound advice. Actually, there was guidance that don't wait till it's there, assume that it's already there. I actually remember a communication piece put out really clearly by the American Healthcare Association that said that specifically. Don't wait till you start getting the virus or people testing positive. It's already there. You need to start assuming that it's spreading right now, and you need to take action. And again, I think that was good advice during the beginning of this pandemic. But just from the dozens and dozens of phone calls we joined at the time and talking to other facilities and really seeing some of the quotes from the facilities that had these catastrophic COVID events, there was kind of this phenomena where that got misinterpreted a little bit, where some felt that, well, if the virus is already here and already spreading and everyone's already exposed, do we quarantine people? Do we separate people? What do we do? And that was just a common, theme that we heard early, in the pandemic. Again, I think that the guidance was sound and it was given with the best of intentions, but during such a hectic time, when you're being told to assume that everyone may already have it, it led to some confusion and people not really knowing what to do. So the resounding answer is yes, anytime you think someone is positive, you need to immediately get them away from someone who isn't positive or someone who isn't, you think, positive. And that goes to another thing that we talked about, or another thing that was planned in the spring. The facilities that were really able to act on this in separating people real quickly were the facilities who during the early days were able to set up COVID-19 dedicated units. And these are like isolation units on steroids. A dedicated COVID unit is an area that is solely for residents who are confirmed to be positive. It needs to be in a part of the building that's separate from residents who are not positive. If you're a facility that just doesn't have the space for that, you need to build some type of barrier or create some type of wing in the facility with a barrier. I think a lot of places used, isolation curtains, and I'm not talking window curtains, but the big, thick, heavy curtains that you'd separate, hospital beds with, or built other structures to separate areas. These dedicated COVID-19 units, the staff there needs to be just that. They need to be dedicated. They can't work on other units. They need to be dedicated specifically to that unit. So if I'm a nurse and I'm working on the COVID unit, caring for COVID residents, I can't go care for residents on a long-term care unit, anytime soon after that. I need to be scheduled there and only there. They need to have their own break rooms. They need to have their own bathrooms. Ideally, they need to have their own entrance and exit into the building. So as you can see, creating these COVID dedicated units, it's like making a building within a building. For facilities, this is and just was a huge challenge. Not only because of all the staffing, issues that places have, just the physical structure of a building would make this difficult depending on where you are. But if for any facility, if they didn't have plans in place to do this in the early spring, or if they hadn't created it already in the early spring and COVID struck that facility, and as we know now, COVID strikes incredibly fast and it strikes incredibly hard. If you didn't kind of already have plans for this or have this already set up, you're going to be in trouble, because it's just not something you can set up overnight. It's a huge process to set up a dedicated COVID-19 unit. So that's something else in the spring that a lot of facilities were doing to get ready. Let's get these areas kind of set up just in case we have an issue with COVID, which I want to stress, didn't feel like a sure thing back in March at all. So those are some of the things that we were doing early on, but then we get to March here, and we see the mass outbreaks in the reports in the news of these horrible events that were happening in nursing homes. We saw, Washington State, we saw some things close to home in Holyoke, but really it was across the country. It was just jaw-dropping, I think, to everyone. The level to which COVID could spread in a facility and how fast it could spread, and really, the destruction it would cause. I think, at the time on a lot of our early phone calls, and these were with, infectious disease experts, from the state or consultants who, have been dealing with infectious disease, they were telling us, facilities need to be prepared. Some folks in your building are going to get this, and some folks are probably going to, pass away, and it's going to be sad, and some staff are going to be infected. So be ready for something like that. It wasn't, we learned in mid-March, it wasn't going to be some folks that passed away. It could hit a building, and you could have, unfortunately, dozens upon dozens of residents pass away in a short amount of time. So once this started to become, more and more clear, CMS made the unprecedented move of banning visitation for nursing homes across the country with little to no notice. It just came and dropped that this was required, and everyone needed to do it as soon as possible. I'm sure some of you on this phone call have family or friends that live in a long-term care facility, or you've worked in a long-term care facility. And as you know, visiting people there is incredibly important. I'd put it almost to the level of, it's a basic human right that you'd have visitors come see you, and you'd be able to come visit your loved ones. So this was a very, very intense thing to have to shut down visitation like this so quickly. The other part about this ban on visitation was that there was no timeline to ending it. There was no plan moving forward where we're stopping visitation this week, and then next week, this is what we're going to do. This was clearly, oh my, stop visitation right now immediately, because we don't know what's going on, and we need to figure this out, and we don't know what's going to happen next. So that was a very unsettling thing that happened in mid-March. Not only for facilities, but for residents and their families. Life changed really on a dime with that initiative. So the next thing that happened a couple weeks after that, mid-March and in early April, was that we started to see the first broad personal protective equipment directives come down. And that first one was mask wearing. Everyone who was in a facility needed to be wearing a mask. Another great idea. In hindsight, it's unfortunate we waited until April and we didn't know sooner, because really everyone probably should have been wearing masks in March, first thing in March, if not February. The problem is, and I can speak to my personal experience in my facility, you know, we usually order 200 masks or so a month. Well, now we need thousands of masks every single week. And so don't the 500 other long-term care facilities in the state, and thousands of other facilities across the country, and thousands of other businesses that need these masks. So the supply chain, you know, wasn't set up to handle that demand all at once. You know, when the initiative came down, it came down on, I think the date was like April 6th. Everyone needs to do it now, or as soon as possible. And you know, it just, the system wasn't able to handle that type of demand right away. So what you saw was just, you know, facilities and buildings going through a nightmare trying to get these masks. And the only thing that were available often were, you know, off-market masks or cloth masks. At some buildings, you know, we've all heard the story, staff had to wear the masks all day or for multiple days. Everyone really needed to conserve. And it was truly just do the best, you know, you can. With PPE, it certainly didn't end there. And it certainly didn't end there with supplies. Another supply, I don't know if this is one that you've heard a lot about in the media, were supplies to take people's temperatures were incredibly scarce. I'm talking specifically about the probe covers to take people's temperatures orally and tympanically in the ear. We started taking the temperatures of every staff member and every resident multiple times a day. And you were eating through these things, you know, thousands by the day. And they were just not able to be delivered or found. There were buildings that were completely out of them. And we heard that on other multiple phone calls, you know, when we have these kind of statewide phone calls, facilities who were voicing concerns that they were completely out of temperature probes and there was no one that could give them to them. Thankfully, you know, we never, you know, ran out of them. But I can tell you right now, we were very close multiple times. There were times where we only had days left and then, you know, we thankfully got a delivery. A solution at the time was thermal forehead thermometers, and those are used very frequently now, but then you just couldn't get them. You'd pay $500 for one on Amazon that usually cost $50, and it would never show up. I tried that personally dozens of times. We never got a single thermal thermometer for months. None of the ones we showed up. Luckily, the nice folks at Amazon reimbursed all the money. But yeah, it just wasn't possible to get anything. N95 masks are another item that, you know, I'm sure everyone has heard of that were scarce. We placed orders for those through very trusted vendors, vendors that we had used for years. And I'm talking about, you know, major $20,000, $30,000 purchases. And again, our vendor said, you know, we have a supplier, they've guaranteed delivery, write us the check, and this is the expected lead time. Never showed up. They just never came. We you know, they'd say, all right, it'd be 3 weeks. Well, that got pushed back to 6 weeks, and then they'd say, well, we'll get it to you in August. And at that point, we'll forget it. I mean, that's 3-4 months away. We need to find something else. But that was very common. Believe it or not, I still haven't even talked about the worst piece of PPE that's been the most difficult, and that's isolation gowns. For those of you who aren't familiar, these are those yellow gowns. They could be green or blue, but you use them once, you throw them away, look like they cost 80 cents. Well, 80 cents is what they did cost. At one point, the cheapest you could find them, they were over $12 each. And we're talking about something that you put on once to enter a room, give a resident medication, or readjust a resident in their bed, and then you take it off and throw it away. You can only use it once if you're using it the way that you're supposed to. That's $12 right there that you just threw in the trash for, you know, a 30-second to 3-minute interaction. Buildings who use these with all residents, which you're, you know, probably required to do in a lot of cases. I mean, you eat through hundreds, if not thousands, of these in a day, and it's definitely thousands in a week. In the percentage, you know, markup that we're on them, we're in the thousands. I mean, like I just said, we went from 80 cents to $12. At one point, facilities in Massachusetts grouped together, and with the help of our trade organization, Massachusetts Senior Care, we were able to place a big order for these gowns, but it still took 3 weeks to get them. And at the cost, it wasn't unheard of for a facility to spend $100,000 to get them a supply of gowns that lasted for a couple of weeks, if not less. You burn through these things like crazy. So PPE at that time was a nightmare. It was just an absolute nightmare. If you've heard that, the stories, I can confirm you're absolutely true. The other enormous problem, which really was at the level of crisis once we got into the pandemic, was the availability of testing. It took an act of Congress to get a COVID-19 test. Residents who we wanted to get tested needed to meet very specific criteria. The symptoms that they needed to have were either fever, cough, or shortness of breath. And they had to have at least one of those 3 symptoms. If not, don't even bother, you know, requesting a test. It would not be provided to the resident. Even if they did have these symptoms, clear signs of COVID, we'd still get rejected for testing if the resident didn't have high-risk exposure or high-risk travel. Has the resident traveled to Wuhan, China in the last 14 days? No, they're a resident of a nursing home. They have not traveled anywhere. Did they attend the Biogen conference in South Boston? No, they did not. Okay, then they don't have an exposure, and this could be flu. We can't give them a test. Our tests are limited. We can't do it. And I'm not exaggerating. It really was that difficult at times to get a test for residents. We had the same exact issue with employees. The criteria was so specific, it was almost impossible for an employee to get a test. And it was just a matter of luck at that point. I mean, some people could get them, some people couldn't. Depended on the doctor, depended on the clinic that you went to. You again needed symptoms, and you needed to have very specific exposure criteria to get that test. Even if you could get one, it usually took a day or two to get it, and results weren't coming back for like a week. And at that point, it's just not that helpful. It just wasn't that helpful to get a test that took you so long to get, and then so long to get the results. So the lack of ability to quickly test residents and test staff made it virtually impossible to identify people who were positive early on in the pandemic, or identify them quickly. And it was problematic on both ends, obviously, because if a resident's positive, you want to know that they're positive so you can isolate them and treat them appropriately. And if a staff member is positive, you know which residents that they cared for and other staff members they potentially exposed, and it gave you useful information to work with to make decisions with. There was no, we were blindfolded at that time. There was no decision-making ability at all based on testing. So in addition to these enormous PPE and testing challenges, there was still another big shoe that hadn't dropped yet. And again, this is kind of this early April-ish time frame. If you remember, I said before, fever, cough, and shortness of breath. That was kind of the holy trinity of symptoms. And that is what we heard over and over again for quite some time. That kind of got beaten into our brains, and they still are very key symptoms for COVID-19. But all of a sudden, new guidance came out, and it was, again, kind of in a panic, in an FYI. It wasn't like, regulatory bodies were trying to hide this. It was, emergent notice. diarrhea, fatigue, change in mental status, unmanageable blood glucose for diabetics can also be key signs of COVID-19. So pretty much anything and everything you think of now could be a symptom of COVID-19. If we add diarrhea, fatigue, and change in mental status to fever, cough, and shortness of breath, I mean, you're talking about half or 60% of the residents in your facility. So when this came, this was another jaw-dropping, piece of guidance to all of us, where it was, wow, anyone could have this. Anyone could have this. So, to recap, the spring, there was little to no testing. There was a PPE shortage that was at crisis level, and staff weren't even wearing masks until April in most facilities. And then the symptoms that we thought were the telltale symptoms, well, they are, but really it could be a lot of other things too. COVID could manifest itself as diarrhea and GI, or it could be residents who are having mental status changes. These things all kind of worked together in combination with lots of other factors. This is incredibly complex, and I don't know if anyone has all the answers, but these were certainly contributing results to massive outbreaks that we saw in nursing homes, where they all had these just catastrophic, not all, but many of them had these catastrophic events where 50, 60, 70% of their residents and staff all got infected in a very short amount of time. So kind of moving on after that, chaotic spring and early days of the pandemic, we got into a period that we called the new normal. That was kind of a catchphrase people started to use. And that was about a 3 to 4 month stretch that I'm sure all of us remember here, that was very, very nice from June until about late September, where there was just this wonderful lull in positivity rates across the entire state. The positivity rate, I forget what it dropped to. I think it might have been as low as 0.4% at one point. But the bottom line, when that positivity rate is less than and when it's down that low, we were really at a point where the virus was no longer spreading and expanding its wings. It was contracting and contracting and contracting. So everything was really, really stable at that time. Facilities were not seeing huge outbreaks, at least not to the extent that they were in the spring. In most places we're pretty under control, and admissions were able to resume, at least on a limited basis. But many things had changed, like the wearing of PPE and testing, and people started to, like I said, refer to this kind of as the new normal. So to talk about some of the things that happened, during this period, in this new normal period, the biggest change may have been the 14-day quarantine period. Whenever, and this still holds true till today, whenever a new admission comes into a building, they have to be quarantined for 14 days, no matter what. There's nothing that can negate that 14-day quarantine period. Well, what if I test negative before I come in? You still have to be quarantined for 14 days because the virus can manifest anytime in that 14-day period. What if I get 2 negative tests in a row within 72 hours? There's nothing that negates the 14-day quarantine period. So what's this mean for the patient that's coming into a facility for rehab? The good news is not much, and actually it means good things for them for the most part, are things that most residents are going to be happy with. It means that they are going to be in a private room. Being quarantined for them on their end simply means that they're not going to have a roommate. On the outside, it means that staff needs to wear full PPE when they go in and out, no matter what. But besides that, it doesn't mean all that much to them. They're going to have their own private room. And that should give them a level of comfort, because they're coming from the hospital and they now know they're not going to be with a roommate who's potentially infected. And I think, I can't speak to this for sure, but I think in the hospital they don't necessarily have all private rooms. I think they're still sharing rooms at hospitals because of just the need, but they'd be coming from, if they were coming from the hospital, they'd be coming to their own private room. For the facility, it's a little bit different of a story. This greatly decreases the bed capacity at facilities. It almost likely is going to cut buildings, to almost in half of what they can take, because they can't put 2 people in a room anymore. They can only put people in one room. So facilities are kind of anxious about that because it's going to impact their census greatly. Rehab. Residents are still going to get rehab, but they're going to get it a little bit differently. And again, I don't think anything that's going to be necessarily a negative experience. It's almost like they're going to have a private rehab gym, because facilities certainly need to put policies and procedures in place to make sure residents aren't interacting all that much in the rehab gym. And there needs to be time in between residents being in there for them to sanitize the equipment. So, before, if you had a nice big rehab gym and you get 5, 6 residents going in there at a time, that's probably only going to be 2 residents right now. There's also going to be no group therapy or no concurrent therapy, which means all the therapy will be one-on-one. And while I certainly think that there's benefits to group therapy, such as socialization and motivation, there's still a lot of benefits to one-on-one therapy. So the residents will get that therapy in that manner now. Testing requirements. Testing is also, widely available now. The days of testing not being available and being so hard to get a tester are over. Right now, and hopefully this doesn't change, facilities have the ability to test in abundance. Now, it's not required that a person be tested before they come into a facility. That's actually something that facilities really can't require. Most hospitals are testing residents before they discharge them, but it's not something that they require. Testing during their stay, facilities have the ability to test residents as needed during their stay and as requested. A resident's never forced to get tested. They're always going to have that choice. But once you're in our building or in most buildings, we'll have the ability to test you as much as you'd like, or is reasonable, or is needed. And we're also able to test people before we discharge them to the community. That's a pretty common practice, something that we have in place that we think is a best practice, that we'd like to get folks a negative test a day or 2 before they go home and re-enter the community. We're getting all our test results back definitely within 48 hours now, and a lot of times it's within 24 hours. So we would give somebody that test about 2 days before discharge. I want to talk a minute separately about surveillance testing, because this is a very, very useful tool that facilities now have at their disposal to protect residents and staff. Surveillance testing is simply the regular and systematic testing of staff and residents who don't have any symptoms. You're doing this broad testing to see if you can find people who are positive and don't know it. If someone is having symptoms and you test them, that's not surveillance testing. That's testing someone because they have symptoms and you think that they'd be sick. Surveillance testing is simply just testing every staff member that works on unit number 1, even though we have no reason to expect that they'd be sick, just because we want to see, geez, is anyone positive and not know it here? We're doing this on a very, very broad and enhanced basis. We're testing every staff member every single week. Many of our staff members, especially the ones who have close contact with residents, I'm talking about nursing and therapy folks, they get tested twice a week. We test all our residents twice a week. If they decline, again, that's their right, but we have very few people that decline. Everyone gets a test twice a week, and they're, for the most part, very happy to be offered that. Surveillance testing, again, is something that's widely available at facilities now, and it's just an important tool for decreasing that spread. It gives you the ability to find people before they become symptomatic. You find people who are positive before they know it, and you can get them out of the building before they get sick, and it really decreases the chances that they're going to spread the virus. Another term that people may see is outbreak testing. If a building has a new case amongst their residents or staff, they may enter what they call outbreak testing. That doesn't mean that the facility is having any type of uncontrolled, outbreaks. They're just going to be enhancing their testing program at that time and really trying to drill down on close contacts, people that may have interacted with that person who tested positive. So they could kind of be in outbreak mode, but really that shouldn't be as scary of a word as it sounds. I don't know if I love the word outbreak, but that's kind of what CMS calls it. So what's resident life like right now, and patient life like right now? Visitation, I put outdoor visits on there. That's something that was happening regularly when the weather was nice. Obviously, the weather's not so nice right now, so we're not having a lot of those, but that will be, it won't be long before the weather's nice again, and outdoor visits, if the pandemic is still at the phase it is right now, will be recommended, and we'll be having those, and you can set up some real nice areas for outdoor visits, and can actually be a real nice time for patients and their families. Indoor visits are allowed, but they're only allowed, and they're becoming more and more scarce, because indoor visits can only happen if a facility has truly had no positive cases amongst their residents and staff within 14 days. And it's very, very rare that that's happening right now, because we're seeing the positivity rates become so high in the community. And when you're doing these broad testing initiatives, you're going to just find staff positive every now and then. And then there's also compassion visits. Compassion visits are really up to the facility. They're kind of a catch-all, where if a resident obviously is end of life, that's going to be an automatic, compassion visit. But also, if a resident is really having a tough time and struggling with depression or some type of mental health issue, the facility has the ability to say, let's just get some family in here to come visit you to help calm you down. And that's certainly something we use regularly. So visits can happen when needed. Dining programs, communal dining is something that's very important. It's a great activity. It has to be done a little bit differently. We can't all eat at the same table like groups right now, much like you do in settings around the world. You have to remain 6 feet apart. So we're still able to do that in innovative ways, but dining certainly looks different, as well as activities, group activities, the concerts we like to do. We just kind of need to be creative when we're doing those, both indoors and outdoors. People need to be separated. There's all types of cool technology you can use. For example, we invested in this kind of headset system where everyone can wear a headset and play games, appropriately social distance, and the person that's hosting the game can talk to everybody. And it really has been a hit. Some people actually like it because they don't have to travel too far to enjoy an activity. So that's been nice. Going back to what short-term rehab looks like now, there are some new processes. We talked about them before in terms of, one-on-one therapy and the gym, being a little bit less crowded and things like that. But there's some PPE requirements. Therapists are always going to have to wear masks and eye protection at a minimum while caring for the residents and providing the therapy. I bring that up because, it's important that, when you're getting therapy, that you can communicate effectively, and sometimes masks provide a little bit of a challenge if a resident's hard of hearing or when they can't read facial expressions. So therapists are just, and all staff, nursing are just getting, really creative in how they navigate that. It's important to have that facial contact. We can't have that right now. So that's a little bit of a change. Also, we do encourage residents to wear face masks when they're outside of the room. So when they're getting their therapy, if they can tolerate it, we like them to wear a face mask, but it's not required. If a resident cannot tolerate a face mask, they're not required to wear one. Discharge planning. We certainly have areas set up in the facility where families can come in and get teaching. We can do that in a safe and socially distant way. We do it outside of care areas, so there's the smallest amount of interaction, needed. Families, when they come in, don't have to go into units or anything like that. They can stay somewhere safe, and we can do teaching and discharge planning in a safe way. We obviously get the question a lot: is it safe to go to a rehab, a facility for rehab? and there's still some more slides we're going to talk about, but I think that it's important to understand that we have some very useful tools at our disposal right now that we didn't have in the past. And those tools are, an adequate supply of PPE and surveillance testing programs that can identify folks that are positive early and often. And obviously just tons of new processes and procedures that have kind of taken hold and we've kind of become stable with. So unfortunately, we are seeing the second wave here. And I actually wrote this slide. I'm looking at it now probably a couple of weeks ago because things have escalated since I wrote this. Facilities are having new outbreaks. I think that number I say approximately 60 facilities had new clusters. That's well over 100 on the last dashboard information that I got. And health experts are starting to agree that the community in which a facility is in really has the most or strongest correlation to that facility having an outbreak. And that's because if a facility is in an area or in a city that's having a high positivity rate, well, the staff of that facility live in the community. They take the bus to work. They go to the grocery store. They live with people that live in the community. And it's more likely that they get the virus in the community and unknowingly bring it into the building. I think that, one of the best quotes I heard is, it's not like the good facilities have figured out a way to stop COVID-19. I think, the facilities that are doing a good job have figured out a way to limit it to the greatest extent possible. But the truth is, there really is no silver bullet yet. Surveillance testing and PPE are useful tools. The only silver bullet will be a safe and effective vaccine that's widely distributed to the community. So sorry this seems like we're jumping around a little bit. I just want to go over those PPE requirements one more time. And this first bullet point here is a correction. I'm wrong when I wrote this. When a resident is in the facility, they are required to wear a face mask if they're outside the room. No, they're encouraged to wear a face mask when they're outside of the room. If they can't tolerate, they don't have to wear a face mask. The staff that's treating a resident has to wear eye protection and a face mask at a minimum. If that facility has had a case of COVID in the last 14 days, the staff is going to be wearing eye protection, face mask, gown, and gloves. So they'll be everything, wearing everything. And I go over some of the barriers that those things cause down there. But again, staff are getting creative with those. I think this is the last slide. So a vaccine. This is a very, very fluid situation, and I think things have probably even changed since the time I wrote this slide. But most facilities about a month ago were let know by their pharmacies that we could expect a vaccine towards the end of January. There's going to be a lot of logistics around the distribution of this vaccine. The first of which is the vaccine has to be kept at -70 degrees. So it's not like something they can send to us or drop off to us and we can distribute. It needs to be stored in special freezers and given in like a flu clinic type format. The vaccine also needs to be given in 2 doses, an initial dose and then a booster dose. Compliance with this, I'm telling, it's not going to be easy. It's tough to get people to show up for a vaccine once. I mean, I think flu shot, vaccination compliance is around 70% on average. Add the fact that they have to come in for a second shot, it's only gonna decrease. I think that a TB test is a good measuring stick for this. Any infection control team will tell you how frustrating it is when they plant a TB test on somebody and they tell the person they have to come back in 72 hours later to get it read. Well, my car broke down or I got sick and I couldn't come in that second time. So hopefully we don't, see a lot of that with the vaccine. The other thing about the vaccine is that it's pretty clear that this makes folks pretty sick for 24 hours, which isn't uncommon with vaccines. So you're not going to be able to give it to all your staff and all your residents all at once. With the staff, you don't want to give everyone a vaccine that they're going to be feeling lousy from for the next day, because then you're going to have no staff to care for your residents. With the residents, you don't want to give it to all your residents all at once, because then you're going to have a building of residents that aren't feeling well. So this is going to have to be staggered a little bit, and you're going to have to do it in phases. The one last thing that I'd mention about staff compliance is another thing that, just the industry-wide we're concerned about is if this vaccine does make people feel kind of lousy, which it's reported to do, well, it's going to be even tougher to get people to want to come in for that second shot. Someone gets this first shot and feels really, really sick, which is possible. It's a tough sell to get them to come back and take that second one when they say, geez, the last one made me feel like, I was dying. You want me to do this again? So the vaccine is a silver bullet if it's as effective as everyone says it is. If it's 95% effective, you can feel comfortable that that's going to provide an incredible amount of protection to people. And if we get lots and lots of folks to take it, then that's going to be a real good situation, and will help turn these things around. But like we're discussing here, there's some dynamics and logistics here that need to be considered. Okay, so I think that's it. Happy to take any questions, Karen.
Yeah, we do have a few questions. I had a little issue with my video, so here we go.
Okay.
The first one is at the beginning of this push. Was there any thoughts or planning with discharging some of your residents earlier to make room for the wave of patients that may be coming in?
Yeah, and absolutely. So when the first wave started and it came to be clear that this was going to be a huge problem, building like ours specifically, where we just have a huge short-term rehab census, we started calling families right away and said, listen, unless it's absolutely necessary and for someone to be here, they really should be discharged home. We did that for two reasons, because people shouldn't have been in a facility at that point unless they absolutely had to, because we felt the risk was so high for facility spread and they'd be safer at home. And number two, we wanted to be able to care for people who became sick or help the community out if the hospitals had overflow. So that was absolutely on the agenda.
So we did hear you say that you cannot require testing of your residents that are going to be admitted. One of the participants works in the hospital, was under the impression that testing was required 48 to 72 hours prior to hospital discharge. Is there clarification on that? So
I guess the first thing I would ask is that Massachusetts? And that the second thing I would say, that might be a hospital policy, or it could be a policy that has been dictated to the hospitals. But on our end, we've been directed to not require testing for any admissions. We can't deny somebody the right to get care on the basis of their test.
This was actually a New Hampshire requirement.
Yeah, it might be different. And like I said, a lot of hospitals are doing that anyways, so it hasn't been an issue. I think that the directive to skilled nursing facilities is that they don't want to condition people their ability to get care on their ability to get a test.
On that same note, are you able to actually accept COVID positive patients?
Yeah, so every facility really should be ready to do that, because if you're accepting patients, the person could become COVID positive when they're there. When it comes to taking people that are actively COVID positive, we haven't got a ton of those, but it's something we have done and we're ready to do if needed.
How are you able to maintain the morale with your staff and residents with all of the requirements as well as lack of visitors?
Yeah. So, I guess the first thing I would say is that the staff has been absolutely incredible. It's just amazing what people can do when they really need to be heroes. that doesn't mean this hasn't been exhausting and really at this point just traumatic for people. I think that back in the spring, when this first wave hit, the way that I describe it is this kind of a prolonged fire drill. You know, your residents are in danger, people are in danger, and you're just doing what you have to do every day to get through it, and you're not really thinking much about it. But then we had this lull in this nice summer, and things kind of felt okay again. And when this has restarted these last couple months, you've certainly started to see really some post-traumatic stress in staff. They just can't believe it's happening again, and some of those feelings are starting to come out. So, you know, all facilities need to be prepared to help their staff cope with that. On the resident level, it's amazing how strong residents and patients are. You know, some of these folks, especially, you know, those who are elderly, I think that we forget sometimes what they've already been through in life, and they are really, you know, prepared to deal with a lot. And the staff has just been incredible, acting as their family and being creative and keeping them engaged and keeping their morale high. And, you know, for the most part, although it's tough not to have visitors, and, you know, it's tough to live differently, for the most part, it's just incredible how high and good the morale has been.
You had mentioned a lot of increased days, 14 could be 14 days on the initial admission, 14 days on prior to discharge for quarantine area issues. Is there any pushback or discussion from Medicare to increase the max days, or are you having any pushback from insurance companies for not paying for that time?
Well, no. So when someone comes into the building, we are required to quarantine them for 14 days, but that doesn't mean they have to necessarily stay in the building for 14 days. A lot of people get discharged before they get to 14 days here. So they're here for 9 days, and that whole time they are in quarantine, but they don't have, you know, then we discharge them home. And, you know, when they're home, they're their own person. They, you know, they don't necessarily need to quarantine at home. We would get pushback from, you know, insurance companies if we said that we're keeping the person here just for the fact of quarantining with no skilled need. But yeah, no, well, they have to quarantine for 14 days while they're here. It's if they're here that long, they can go home without that. Discharging folks hasn't been an issue. Yeah, we're able to get people home pretty quickly.
Is there any discussion of any financial assistance to your facility for the additional cost of care and PPE?
Yeah, so the CARES Act provided, you know, some funding to skilled nursing facilities, and the payroll protection program was something that, you know, was designed for you know, healthcare facilities in mind. I think not only healthcare facilities, but, you know, we're certainly the type of organization that benefits from it because we need to pay our staff, and we were going to have decreased revenue. So there's no doubt about it that this has been an incredible financial burden, despite the assistance from the government. And, you know, we're pushing for more. Trade organizations are pushing for more for us. There needs to be more for us. So we're hoping we get it. But yeah, there's tons of discussion. We need a lot of financial help. Our census just isn't the same as it once was.
Just one more question here. And are you finding the use of telehealth to assist your residents in their care outside of your facility helpful?
Yeah, so telehealth it's good. It depends a lot on the resident. You know, some residents just aren't able to participate in it that well or get a little bit confused by it. And our nursing staff certainly, you know, wants to help and is able to help. So overall, I'd say, yes, it's been helpful, but as you can imagine, a little bit more helpful for some residents than others.
So that was the last question.
Okay.
And I want to thank both you and Naomi for helping Case Management Society of New England for providing this program tonight and taking the time to do so.
We're very happy for you to have us. We thank everyone so much, and we hope everyone stays safe.
Thank you. You too.
All
Good
right.
night.
Good night.